Welcome to Chapter 32, entitled Pharmaceutical Care for Cancer Outpatients. In recent years, the number of oral anti-cancer agents, abbreviated as OACA, protein kinase inhibitors, PKI or NIBs, in particular, has sharply increased. In the near future, the rise is likely to continue. Oral anti-cancer agents are used in the treatment of both common cancer types and a wide variety of less commonly occurring cancers and hematological malignancies. Due to the spreading use of oral anti-cancer agents in cancer treatment, pharmacists and staff of outpatient pharmacies are becoming more closely involved in the disease's main treatment and directly interact with predominantly older cancer patients and other caregivers. Providing pharmaceutical care for cancer outpatients requires specific knowledge of cancer, drug, therapy, pharmacogenomics, contraindications, interactions of oral anti-cancer agents with other drugs and food, side effects, and their management and patient education. Within the framework of a multidisciplinary team effort, the pharmacist dispensing oral anti-cancer agents must assess the suitability of its use for the patient and address eventual problems that the treatment entails, notably with respect to supportive and current medication for chronic diseases. The pharmacist is also responsible for adequate patient counseling. Adherence to oral anti-cancer agents treatment and effects brought about by oral anti-cancer agents and co-medication require careful monitoring of the patient and his/her use of medication. Close collaboration with other healthcare providers, both in the case of prescribing oral anti-cancer agents and co-medication and with respect to events occurring during the course of treatment as the result of disease progression, side effects or incorrect medication use, is the most appropriate way to resolve eventual problems and adequately adjust treatment. In the present chapter, the various steps of the pharmaceutical care process, conditions for its successful completion and the role of the pharmacist in it, are lined out, and the main topics that have to be addressed during this process including the detection and management of drug interactions, the reporting and management of side effects, non-adherence and adherence supportive care, and last but not least, patient counseling are discussed. The basic approach is that pharmacists are partners of primary care physicians as they collaborate on a wide variety of care activities including the optimization of treatment, medication reconciliation, patient education, and medication safety. We will now look at an introduction. Since the highly successful introduction of capecitabine and imatinib in the years just after the beginning of the present century, the number of oral anti-cancer agents, abbreviated as OACA, protein kinase inhibitors, abbreviated as PKI or NIBs, in particular, has sharply increased. In the near future, the rise is likely to continue. Oral anti-cancer agents are used both in the treatment of common cancer types like breast, colorectal, lung, and prostate cancer and a wide variety of less common cancers and hematological malignancies including chronic myelogenous leukemia, multiple myeloma, kidney, and liver cancer. As the result, the number of cancer outpatients on active treatment has considerably increased. Since most oral anti-cancer agents are very expensive, in many countries they are only available under special arrangements and/or are dispensed by hospital outpatient, or specialist pharmacies. However, supportive medication like antibiotics, antiemetics, antiviral drugs, bone-stabilizing drugs, and analgesics as well as medication for chronic diseases is often still dispensed by community pharmacies. Pharmaceutical care for cancer outpatients clearly requires specific knowledge with respect to cancer, drug, therapy, adverse effects, contraindications, interactions of oral anti-cancer agents with other drugs, and patient education. Therefore, it is highly important that pharmacists have the capacity to adequately deal with cancer patients using oral anti-cancer agents and their specific health problems. We will now look at the etiology of cancer. The term cancer covers a wide range of malignant diseases that cause irreversible tissue damage by uncontrolled cell growth, which results in the formation of neoplasms in organs and tissues, that is, solid tumors, or an abnormal increase and accumulation of malignant cells in bone marrow and the lymphatic system, that is, hematological disorders. This is the ultimate effect of a defect in our genetic material, DNA, RNA, caused by hereditary or acquired, that is, somatic, mutation, a virus infection, radiation, or exposure to a chemical or otherwise toxic substance. Cancer-related alterations predominantly concern the genes of proteins involved in processes like cell division and growth, programmed cell death, apoptosis, and DNA repair. Abnormal gene activity and the resulting interaction of the various proteins produced and/or malfunctioning of signal transduction pathways disrupt the normal cell cycle. This results in a decreased or less effective regulation of normal cell growth and an increased risk of neoplasm formation. In the case of a solid tumor, the affected cell forms a microscopic tumor which develops into a primary tumor. In a subsequent phase, the tumor spreads to other organs and tissues and causes metastasis at the site where cells originating from the primary tumor are nesting. The process of tumor formation repeats itself. Next we will discuss cancer treatment. Let's begin with curative treatments. Curative treatment intending to cure a cancer or achieve long-time control of tumor growth, or the accumulation of malignant blood cells, usually results in a substantial extension of life. Curative treatment strategies have shown to be particularly effective in patients with whom the disease has not yet spread. Treatment primarily consists of tumor removal by means of surgery or the eradication of malignant stem cells and their replacement by normal cells, stem cell transplantation. Radiotherapy may also be used to eradicate tumors, or reduce their size, after which the remainder can be dealt with by means of surgery. Malignant cells that not have been cleared by primary treatment or the possible presence of non-detectable, that is, micrometastases, can be challenged by radiotherapy, chemotherapy, and/or immunotherapy. And now let's look at adjuvant and neoadjuvant treatments. Adjuvant treatment concerns the use of chemotherapy, hormonal therapy, or immunotherapy after surgery in order to eliminate remaining malignant cells and reduce the risk of recurrence. Neoadjuvant treatment usually relates to chemotherapy given prior to surgery. The simultaneous application of radiotherapy and chemotherapy is referred to as chemoradiotherapy. Next we will discuss palliative treatment. After spreading of the disease, also called metastasis, to other tissues or the uncontrollable formation of massive amounts of dysfunctional blood cells, curative treatment is no longer an option. Treatment is now restricted to addressing the symptoms resulting from disease progression, particularly the relief of pain and preservation of bone integrity, and combating infections as well as uphold the quality of life. In the treatment of advanced or metastatic disease, chemotherapy and immunotherapy are the most important options. Surgery and irradiation have now largely become supportive, that is, combination treatments. We will now focus on treatment lines and treatment intensity. Common cancers are treated with a major part of the older anti-cancer drugs, mostly in fixed combinations. New drugs, particularly oral anti-cancer agents and monoclonal antibodies, are constantly being added. Marketing authorization for new cancer drugs are mostly obtained only for use in second-line or later treatment, i.e. treatment after one or more other therapies. In the case of successful drugs, with additional studies, use in first-line, i.e. as treatment of first choice, often follows over time. Patients are generally treated till disease progression and then switch to the next line. Sometimes, patients are treated beyond progression with the aim of slowing this process on the basis of residual activity, e.g., the continued use of trastuzumab in patients with metastatic HER2 positive breast cancer. If patients are not treated continuously, anti-cancer treatment often consists of a number of cycles, usually 4 to 6, comprising a period of active treatment followed by a period without treatment, often to recover from adverse effects. The patient's overall health status, usually expressed by an ECOG 0, 1, 2, 3, 4, 5, or Karnofsky, that is 50, 70, 90%, score is an important parameter determining both the choice of the first-line treatment and its intensity, dose and dosage interval. A low ECOG score, that is 0, or high Karnofsky score, greater than 90%, means that the patient is not yet, or only to a very limited extent, restricted by the disease in performing her or his daily activities and is in a reasonable or good physical condition, and therefore can be treated more intensively. Age is also an important treatment parameter, among several other factors, as the consequence of a reduced liver or kidney function. Elderly patients generally tolerate intensive treatment less well than younger patients. The same holds true for patients with comorbidities, which as such are also more frequently present in elderly patients. Since the activity of enzymes involved in drug metabolism is increasingly associated with their genetic makeup, that is genotype, the prominence of genetics as a factor determining the intensity of treatment as required for not only an effective but also safe use of oral anti-cancer agents is rising. See below. Next we will discuss anti-cancer agents and their use. Let's begin with conventional agents. For decades, systemic anti-cancer treatment mainly consisted of intravenously administered chemotherapy with alkylating agents, antimetabolites, vinca alkaloids, antibiotics, platinum compounds, and taxanes. Use in the neoadjuvant setting or as first-line therapy of metastatic disease generally concerns treatment with combinations of these agents in cyclic dosing regimens, for 4 to 6 cycles, in which each cycle of 2 to 3 weeks consists of a number of days of administration and a short break, that is 1 to 2 weeks, to recover from side effects. With the exception of carboplatin, which is dosed on the basis of the area under the curve, conventional systemic chemotherapy is usually dosed on the basis of the patient's body surface area, but adjustment is required in the case of overweight and underweight patients. Dosing also depends on organ function. Treatment with conventional agents often produces serious, hematological, side effects. Next we will discuss oral anti-cancer agents and monoclonal antibodies. Let's begin with conventional oral anti-cancer agents. Older oral anti-cancer agents mainly comprise alkylating agents and antimetabolites like cyclophosphamide, chlorambucil, melphalan, and methotrexate. Capecitabine, the oral prodrug of the antimetabolite 5-fluorouracil, abbreviated as 5-FU, has been one of the first widely used newer oral anti-cancer agents. In contrast to 5-fluorouracil, given by bolus infusion in a combination regimen or continuously over 1 to 4 days at the start of a treatment cycle, capecitabine is mostly used on the basis of a twice-daily regimen for 2 weeks followed by a 1-week rest period. Apart from the hand-foot syndrome, its toxicity profile is more favorable than that of 5-fluorouracil. In addition to its use in metastatic breast cancer, capecitabine has now largely replaced 5-fluorouracil in colorectal cancer treatment regimens combining 5-fluorouracil with oxaliplatin, that is FOLFOX and CARPOX, or irinotecan, that is FOLFIRI and CARPIRI. The use of oral anti-cancer agents in hormonal therapy, abbreviated as HT, is also well established. Aimed to prevent recurrence after initial curative treatment of early hormone receptor, abbreviated as HR-positive breast cancer, estrogen function is suppressed by adjuvant hormonal therapy using tamoxifen, a selective estrogen receptor modulator, abbreviated as SUM, or an aromatase inhibitor like anastrozole, exemestane, and letrozole. Since they lower estrogen production in fat tissue, the use of aromatase inhibitors is restricted to postmenopausal women. In hormonal therapy, oral anti-cancer agents are used alone or given consecutively over a 5 to 10 year treatment period. In women with metastatic hormone receptor-positive breast cancer, hormonal therapy is used to retard disease progression. In the case of hormone-sensitive metastatic prostatic cancer, 90% of patients, hormonal therapy comprises the use of non-steroidal androgen receptor blockers, especially when the disease has become castrate-resistant. These oral anti-cancer agents include bicalutamide, enzalutamide, flutamide, and nilutamide. Metastatic castration-resistant prostate cancer can also be treated by androgen synthesis inhibitors such as ketoconazole, aminoglutathione, and abiraterone acetate, last treatment line. The daily use of hormonal therapy continues until the disease becomes refractory. Next we will discuss newer oral anti-cancer agents and monoclonal antibodies, used as targeted therapy. The vastly increased knowledge of genomics and molecular biology, including the role of tumor-associated genetic mutations and signaling pathways involved in processes like cell proliferation, programmed cell death, also called apoptosis, tumor angiogenesis, and cell migration, has led to the development of drugs that specifically target abnormally functioning proteins and intracellular signaling pathways sustaining the growth and proliferation of cancer cells. Successful application of targeted therapy, as the clinical application of these new drugs is referred to, therefore often requires genetic testing as part of the diagnosis. Targeted therapy can be administered either intravenously, monoclonal antibodies, or mAbs, or orally, small molecules like protein kinase inhibitors and immunomodulants. The majority of protein kinase inhibitors are multi-kinase inhibitors acting simultaneously on several kinases, e.g. serine, threonine, and tyrosine kinases. In contrast to mAbs, which interact with proteins on cell surfaces and present in blood, protein kinase inhibitors interact with protein kinases that are part of an intracellular signaling pathway. Most protein kinase inhibitors are used continuously in a fixed-dose regimen. And now we will discuss pharmaceutical care. The increasing use of oral anti-cancer agents in cancer treatment leads to a pharmaceutical care process in which pharmacists of outpatient pharmacies are more closely involved in the disease's main treatment. In a coordinated effort with other healthcare providers, abbreviated as HCP, pharmacists, and pharmacy staff, now directly interact with the patient and other caregivers. Importantly, as compared to conventional hospital-based cancer care and treatment, patients themselves now carry ultimate responsibility for taking their medication and reporting side effects. This, however, may cause patients to adjust or even abandon treatment. particularly when side effects are not recognized as such or inadequately attended to. Collaboration with other healthcare providers in the form of a multidisciplinary team, abbreviated as MDT, accompanied by continuous consultation and exchange of information, or access to, especially in the case of problems and disappointing treatment results, is another critical factor in the successful completion of this care process. See also Chapter 5. The pharmaceutical care process at the start of oral anti-cancer agents treatment essentially consists of 3 stages that can be clearly defined. 1. Check and verification, especially with regard to existing co-medication. 2. Dispensing of medication and patient counseling. And 3. Monitoring of treatment, eventual adjustment, and providing patient support, as shown in Table 32.1. The first phase mainly consists of checks and verification. Is the medication record complete? Does the selected medication, oral anti-cancer agents and co-medication, suit the patient with respect to genetic profile, health status, and living conditions? Are there any, potentially, harmful interactions with other drugs, including contraindications? Have the appropriate dose and dose regimen been selected? In addition to dispensing, subsequent steps, that is Stage 2, are mainly focused on the provision of information and advice, particularly with regard to the handling and use of the medication, treatment effects that can possibly be observed by the patient, anticipated side effects, and their management, and the setting up of a treatment support structure as part of the multidisciplinary team effort, as shown in Table 32.1. The best means to achieve this is to discuss these matters with the patient on the basis of a structured questionnaire, structured interview. Issues emerging from the first phase should be verified and discussed. In this respect, the patient should also be asked about the use of OTC drugs and dietary supplements. Treatment finally needs to be tailored to the limitations, needs, and wishes of the patient, especially when oral anti-cancer agents and/or co-medication have to be taken on an empty stomach. Providing information on specific measures regarding contraception of the patient and his or her partner is often also required. This first meeting is ideally suited as a start in building a relationship of trust with the patient and his or her carers, as needed to achieve optimal treatment outcomes. However, an important condition for maintaining this much-needed relationship is that a patient should always be able to contact a healthcare provider he or she already knows and who is familiar with the patient's case. In this context, it is also highly appropriate if the pharmacist already has been introduced to the patient by prescribing multidisciplinary team members, and that in turn the patient is introduced to pharmacy staff involved in the pharmaceutical care process of dispensing and monitoring. Follow-up, that is Stage 3, essentially consists of 2 phases. In addition to dispensing the first refills, short-term monitoring, that is 2 to 12 weeks, mainly consists of asking the patient after her experiences with the new treatment, the occurrence of acute side effects, and offering support in managing these effects, as shown in Table 32.2. Subsequent refills and long-term monitoring depend on a wide variety of factors including the disease and its course, treatment aim, curative, preventive, or palliative, and duration, efficacy of treatment, and side effects, and the attitude and condition of the patient as well as his or her living conditions. It is also important to adjust doses in the case of serious weight loss and stop any medication that becomes redundant, that is deprescribing. The main objective is to enable the patient to successfully continue oral anti-cancer agent treatment and co-medication as long as deemed necessary and useful. Main pharmacist activities therefore consist of monitoring treatment with respect to elicited effects and adherence, and supporting the patient in the management of side effects and symptoms of disease progress, as well as addressing anxiety and concerns about treatment in a collaborative fashion with the prescribing healthcare provider and oncology nurse. In the case of any major change of medication, possibly as the result of adjustment due to disease progress, intolerance or side effects, the entire process or certain relevant parts of it should be repeated, but in a fashion as described in Chapter 6. Particularly with respect to the steps involving checks and verification of dosage, interactions, contraindications, co-medication, current information from electronic, medical and pharmaceutical files is indispensable. Data review is faster when these databases are linked, or have been integrated, and the information can be shared without additional effort. In later stages of the process, electronic pharmacy information systems are also highly useful, notably for the recording of information about the course of the treatment and interventions. However, the use of these systems does not mean that the different steps of the care process can be conducted in a less careful manner than without their involvement. Moreover, successful implementation of the pharmaceutical care process requires commitment, continuous training, consultation, and evaluation, as well as ample experience. The rapidly growing number of anti-cancer drugs, including oral anti-cancer agents, is accompanied by a massive flow of data which must be classified, evaluated, and made accessible to the healthcare providers involved in the daily treatment of cancer patients. It has become virtually impossible for these healthcare providers to perform these activities themselves. Therefore, national or regional centers should be established where relevant information concerning all aspects of treatment is collected, evaluated, and processed, and made available, e.g. by means of a dedicated app or website, and/or linked to the electronic information systems used by healthcare providers involved in cancer care. Although being elaborate, the above-mentioned pharmaceutical care effort for cancer outpatients, as it is closely linked with the medical care process, is likely to pay off in the form of better treatment outcomes, less problems and hospital admissions, and an increase in patient satisfaction. Pause the video and carefully scrutinize Table 32.1 summarizing collaborative pharmaceutical care process before advancing to the next slide. Pause the video and carefully scrutinize Table 32.1 summarizing collaborative pharmaceutical care process before advancing to the next slide. Pause the video and carefully scrutinize Table 32.1 summarizing collaborative pharmaceutical care process before advancing to the next slide. Next we will discuss dosing of oral anti-cancer agents. When oral anti-cancer agent treatment has been decided upon, pharmacists must ensure that the correct dosing regimen is selected. However, largely as the result of side effects or as a measure to avoid their occurrence, dose regimens frequently need to be adjusted, particularly in the case of elderly patients and patients with a reduced liver and renal function. As in the case of oral anti-cancer agents like capecitabine, lenalidomide, and sunitinib, which are used with predetermined rest periods, it might be required to insert additional rest periods. With regard to metabolic issues, genetic testing prior to treatment should be used to optimize individual dosing regimens, notably with respect to cytochrome P450, abbreviated as CYP, enzymes in the liver, see 7.7.7.2. It is well known that patients with partial dihydropyrimidine dehydrogenase deficiency, abbreviated as DPD, using 5-FU or capecitabine without proper dose adjustment experience severe or lethal toxicity due to a lack of metabolic capacity. Although guidelines for dosing patients with dihydropyrimidine dehydrogenase deficiency mutations are available, in clinical practice dihydropyrimidine dehydrogenase deficiency status is as yet not routinely assessed. Dosing can be personalized by means of adjustment on the basis of the actual drug exposure as obtained by means of therapeutic drug monitoring, abbreviated as TDM. As yet, therapeutic drug monitoring is not commonly used in oncology. One of the main conditions for therapeutic drug monitoring is the existence of a clear relationship between exposure, e.g. the area under the plasma concentration time curve, abbreviated as AUC, and the response to treatment, efficacy or toxicity. However, the number of oral anti-cancer agents for which a relationship between drug exposure and treatment outcome has been established, is growing. A more widespread use of the dried blood spot, abbreviated as DBS, sampling technique may also contribute to the development of more personalized therapeutic drug monitoring-based treatment regimens with oral anti-cancer agents. In dried blood spot, a minute amount of whole blood, obtained by means of a finger prick, is collected on paper by the patient at home and sent by the patient to a laboratory for analysis. In the near future, this method, which has shown to be feasible and cheap, may be of major importance in optimizing oral anti-cancer agents dosing. Next we will discuss oral anti-cancer agents and drug interactions. Let's begin with monitoring of drug-drug interactions. Cancer patients often use a considerable number of drugs. Not only those required to treat their malignancy and its symptoms, but also drugs to contend with treatment-induced side effects and comorbidity, largely in the form of a chronic disease. Oral anti-cancer agents generally have a narrow therapeutic index. Particularly patients continuously treated with oral anti-cancer agents are therefore highly susceptible to drug-drug interactions, abbreviated as DDI. Drug-drug interactions may affect the effectiveness of cancer treatment and that of other drugs, result in or exacerbate side effects, and ultimately contribute to a reduced quality of life. The likelihood of drug-drug interactions increases with age, mainly as the result of the increased use of drugs in the elderly, their decreased metabolic, liver function, and excretory, renal function capacities, and altered eating habits or decreased appetite. Indeed, that is, potential drug-drug interactions have found to be very common among elderly cancer patients using oral anti-cancer agents. Both the number of comorbidities and the number of over-the-counter drugs used have been identified as determinants. Although the detection of potential drug-drug interactions is therefore an integral part of the prescription process, or at least should be executed immediately afterward, drug-drug interactions monitoring must be continued throughout the entire period of treatment. At present, electronic pharmacy information systems generally feature the automated monitoring of interactions and also give recommendations to avoid interactions. Adequate monitoring, however, can only be performed when the medication record is up to date and complete, and preferably includes data on the use of OTC medicines, relevant lab values, and nutritional supplements. Monitoring, however, is a problem in cancer patients using oral anti-cancer agents, as they are treated both by hospital specialists and general practitioners, abbreviated as GP, and medication is often provided by various pharmacies like hospital outpatient and community pharmacies or specialist dispensing services. Verification of medication prior to the check on interactions is therefore always mandatory. To this end, a transfer of medication data should be accomplished as soon as patients are admitted to or discharged from hospital or otherwise change from one care setting to another. The availability of integrated electronic patient and medication records may solve this issue. We will now progress to oral anti-cancer agents-related drug-drug interactions. Oral anti-cancer agents use is susceptible to both pharmacokinetic and pharmacodynamic drug-drug interaction. The latter category refers to interactions brought about by drugs with a similar mechanism of action or exerting directly interacting effects. The effect can be additive, synergistic, or antagonistic. The latter effect may result in toxicity like QTc prolongation, occurrence of gastrointestinal and CNS effects, or increased toxicity due to non-steroidal anti-inflammatory drug-induced impairment of kidney function. Drug-drug interactions in oral anti-cancer agents treatment most frequently observed are those between oral anti-cancer agents and coumarins, e.g. capecitabine, quinolones, anti-epileptics, carbamazepine, and phenytoin, and diuretics, especially hydrochlorothiazide. Absorption can be impaired by drug-induced mucositis and diarrhea. These side effects commonly occur as the result of anti-cancer drug treatment. Several oral anti-cancer agents require acid conditions for absorption. The simultaneous use of drugs that decrease acidity in the stomach like H2 antagonists, proton pump inhibitors, abbreviated as PPI, and antacids, therefore, affects the absorption of several protein kinase inhibitors, including axitinib, dasatinib, erlotinib, gefitinib, imatinib, lapatinib, and pazopanib, and reduces their bioavailability. Oral anti-cancer agents absorption can also be affected by an interaction with intestinal P-glycoprotein and the intestinal cytochrome P453A4 enzyme, CYP3A4. Finally, a drug-induced increase or decrease of the volume of distribution as caused by edema and dehydration, respectively, may also affect oral anti-cancer agents' bioavailability. A great number of potential interactions regarding the metabolism of oral anti-cancer agents is brought about by CYP enzymes in the liver, which account for about 75% of the total drug metabolism. Oral anti-cancer agents' CYP-mediated metabolism as such may be influenced by genetic polymorphisms, notably those present in the CYP2D6, CYP2C19 and CYP2C9 enzymes. The presence of certain polymorphisms accelerates or reduces CYP-mediated metabolism. This may be the cause of substantial inter-individual oral anti-cancer agents' plasma level variability, which often also has considerable clinical impact. Likewise, polymorphisms altering drug efflux transporter activity in the intestine, liver, and kidney influence the uptake and excretion of several oral anti-cancer agents. Pharmacogenetic screening of patients using oral anti-cancer agents is therefore increasingly used as a tool to optimize treatment efficacy and avoid excess toxicity. Oral anti-cancer agents themselves may also increase or decrease the activity of CYP isozymes. In this respect, the majority of protein kinase inhibitors is primarily metabolized by CYP3A4. Hence, both CYP3A4 inhibiting and inducing drugs may exert substantial influence on oral anti-cancer agents' metabolism and thereby cause treatment inefficacy and/or adverse drug reactions. Likewise, the reverse may also occur. Inhibition of CYP3A4 by imatinib may cause plasma levels of simvastatin and atorvastatin to rise, leading to myopathy. Certain protein kinase inhibitors including lapatinib, nilotinib, and sunitinib induce QTc interval prolongation. CYP3A4 inhibition by co-medication, e.g. antiemetics, antibiotics, and antifungals, might result in life-threatening toxicity. Next we will discuss drug-food interactions. Drug-food interactions, abbreviated as DFI, of protein kinase inhibitors may be related to the concomitant use of grapefruit juice, which is a potent inhibitor of intestinal CYP3A4 and therefore increase the bioavailability of these drugs. The reverse effect can be observed in the case that St. John's wort is used concomitantly as it induces CYP3A4 and P-glycoprotein. Although food raising the gastric pH may affect the absorption of certain oral anti-cancer agents, combining the intake of oral anti-cancer agents, particularly of certain protein kinase inhibitors, with fatty food often improves the bioavailability of these drugs. On the other hand, this, potentially, increases variation and may be the cause of toxicity. In order to avoid problems, the marketing authorization of several oral anti-cancer agents recommends using these drugs in the absence of food. However, in daily practice for many patients, the use of their medicines under fasting conditions is highly inconvenient and they do not comply with this requirement. For a number of protein kinase inhibitors, including erlotinib, lapatinib, nilotinib, and pazopanib, the effect of the simultaneous intake of food on their bioavailability has been investigated. Although dose adjustments may be required, preliminary study data suggest that they can be safely used in combination with food. Particularly in combination with therapeutic drug monitoring, the standard use of oral anti-cancer agents used at lower dose levels in combination with food may become an option. Nevertheless, in the case that oral anti-cancer agents cannot be used in combination with food, patients should be carefully informed and given advice how to handle this intake restriction. And now let's look at the management of disease symptoms and side effects. Nearly all patients using oral anti-cancer agents experience side effects which may be caused both by their anti-cancer medication and their supportive treatment, which is generally used to treat symptoms stemming from the metastatic disease itself, or side effects directly resulting from treatment with anti-cancer drugs, e.g. blood and laboratory abnormalities, bone effects, pain, seizures, and skin effects, or other means, e.g. irradiation, or surgery. Disease-related symptoms are mostly organ-specific, but often also have a general or psychological nature, including loss of weight, reduced appetite, fatigue, and depression. In view of their exhaustive and demoralizing effect, these symptoms should be explicitly dealt with within the context of the multidisciplinary team effort. Suppression of bone marrow activity leading to thrombocytopenia, neutropenia which increases the risk of infections, and/or anemia causing fatigue, is a prominent and often dose-limiting side effect that is not only specifically related to the use of most conventional IV-administered anti-cancer agents, but also to protein kinase inhibitors inhibiting BCR-ABL and JAK proteins, as well as radiotherapy. Dependent on the type of stem cell most sensitive to a certain anti-cancer drug, the use of these anti-cancer drugs usually results in a specific pattern of bone marrow suppression. Neutropenia-related infections are commonly treated with antibiotics and/or antimycotics. However, neutropenia and its consequences can be attenuated or even prevented by growth factor co-treatment. Non-hematological side effects of conventional, oral, chemotherapy include alopecia, mucositis, nausea, vomiting, diarrhea, neuropathy, and changes in fertility and sexuality. Toxicity brought about by newer oral anti-cancer agents is strongly related to their mechanism of action, and combinations of side effects are often unique to certain drug categories. In addition to the above-mentioned effects, specific effects commonly observed in patients using targeted therapy include skin rash, with EGFR, HER2, mTOR and RAF inhibition, hypertension, with VEGFR inhibition, proteinuria, with VEGFR inhibition, wound healing complications, hand-foot skin reactions, and various vascular complications, with VEGFR inhibition, various laboratory abnormalities, with ALK inhibition, cardiac abnormalities, and hypothyroidism, with BCR-ABL inhibition. Protein kinase inhibitors treatment may also result in hyperglycemia, with BCR-ABL, PI3K, AKT, and mTOR inhibition, and is also associated with specific ocular and pulmonary toxicity. And now let's look at the management of disease symptoms and side effects. Nearly all patients using oral anti-cancer agents experience side effects which may be caused both by their anti-cancer medication and their supportive treatment, which is generally used to treat symptoms stemming from the metastatic disease itself or side effects directly resulting from treatment with anti-cancer drugs, e.g. blood and laboratory abnormalities, bone effects, pain, seizures, and skin effects, or other means, e.g. irradiation or surgery. Disease-related symptoms are mostly organ-specific, but often also have a general or psychological nature, including loss of weight, reduced appetite, fatigue, and depression. In view of their exhaustive and demoralizing effect, these symptoms should be explicitly dealt with within the context of the multidisciplinary team effort. Suppression of bone marrow activity leading to thrombocytopenia, neutropenia which increases the risk of infections, and/or anemia causing fatigue, is a prominent and often dose-limiting side effect that is not only specifically related to the use of most conventional IV-administered anti-cancer agents, but also to protein kinase inhibitors inhibiting BCR-ABL and JAK proteins, as well as radiotherapy. Dependent on the type of stem cell most sensitive to a certain anti-cancer drug, the use of these anti-cancer drugs usually results in a specific pattern of bone marrow suppression. Neutropenia-related infections are commonly treated with antibiotics and/or antimycotics. However, neutropenia and its consequences can be attenuated or even prevented by growth factor co-treatment. Non-hematological side effects of conventional, oral, chemotherapy include alopecia, mucositis, nausea, vomiting, diarrhea, neuropathy, and changes in fertility and sexuality. Toxicity brought about by newer oral anti-cancer agents is strongly related to their mechanism of action, and combinations of side effects are often unique to certain drug categories. In addition to the above-mentioned effects, specific effects commonly observed in patients using targeted therapy include skin rash, with EGFR, HER2, mTOR and RAF inhibition, hypertension, with VEGFR inhibition, proteinuria, with VEGFR inhibition, wound healing complications, hand-foot skin reactions, and various vascular complications, with VEGFR inhibition, various laboratory abnormalities, with ALK inhibition, cardiac abnormalities, and hypothyroidism, with BCR-ABL inhibition. Protein kinase inhibitors treatment may also result in hyperglycemia, with BCR-ABL, PI3K, AKT, and mTOR inhibition, and is also associated with specific ocular and pulmonary toxicity. Next we will discuss adherence. Apart from the issues about adherence discussed in Chapter 4, there are additional concerns in patients using oral anti-cancer agents. It is generally assumed that patients with a life-threatening disease take their medication as prescribed. However, adherence to anti-cancer drugs in long-term treatment has proved to be a constant source of serious concern. Adherence rates of patients using oral anti-cancer agents range from less than 20 to 100%. Effective hormonal therapy in adjuvant treatment of breast cancer requires women to take their medication once daily for a period of at least 5 years. However, because of side effects, about 30 to 50% of these patients discontinue treatment prematurely while intake interruptions are frequent. Adherence to capecitabine seems to be higher and amounts to 80 to 100%. Of patients with CML treated with imatinib, about 1/3 was found to be not or only partially adherent. Overuse of anti-cancer medication may occur as well. Overuse has even been reported in the setting of a clinical trial in which patients are more closely observed than in daily practice and may be intended. Over-adherence of unintended. Over-adherence particularly occurs in patients with complex dosing regimens. The consequences of over-adherence can be serious, as overdosing may produce serious side effects. Suboptimal medication adherence may have serious consequences. An adherence rate, abbreviated as AR, of 90 or 95% is often considered the threshold for sustained effectiveness of oral anti-cancer agents treatment. The impact of non-adherence on the response to imatinib therapy in CML is well known. Only 29.3% of patients with an adherence rate of 95% achieved a major molecular response, whereas 94.5% of the patients with an adherence rate of greater than 95% achieved this outcome. In patients with NSCLC using erlotinib, a threshold adherence rate of 95% was associated with the extent of disease control. Furthermore, in children with an adherence rate less than 95% to treatment with 6-mercaptopurine, the risk of relapse of acute lymphoblastic leukemia was increased by 2.7-fold. These examples clearly show that in cancer treatment, high adherence rates are mandatory to achieve a successful long-term outcome. However, either in a disease or drug-dependent manner, a certain level of non-adherence might be tolerated, since the lowering of initially prescribed doses of capecitabine in the course of treatment as necessitated by side effects was found not to compromise effectiveness. The occurrence of serious side effects is one of the most important factors promoting non-adherence, as shown in Table 32.2. Other factors of non-adherence directly related to treatment are the number of co-medication, duration of treatment, and higher out-of-pocket costs for the medication. Patients' beliefs about the medication are also an important factor, as well as age, elderly and adolescents, and depression. Healthcare provider-related factors, usually related to physicians or nurses, also influence medication adherence. A positive effect was associated with a strong healthcare provider-patient relationship, trust in the healthcare provider, and shared decision-making. A lack of healthcare provider support, insufficient information about treatment options, the experience of side effects of which patients were not informed in advance, and the frequent change of physicians during follow-up were related to a negative effect. Although improving medication adherence to oral anti-cancer agent treatment is urgent, it has been shown to be a challenging task. In spite of decades of intensive research, evidence for effective interventions to improve medication adherence and thereby clinical outcomes is still thin. Current intervention methods to enhance medication adherence for chronic health problems are mostly complex, and evidence demonstrating their effectiveness is mostly inconsistent. However, several projects to promote adherence by applying e-health and m-health-based tools to involve and motivate patients seem to yield promising results. Pause the video and carefully scrutinize Table 32.2 summarizing adherence and support to oral anti-cancer agent treatment, contributing factors, interventions, and tools before advancing to the next slide. Pause the video and carefully scrutinize Table 32.2 summarizing adherence and support to oral anti-cancer agent treatment, contributing factors, interventions, and tools before advancing to the next slide. We will now switch gears to tailoring oral anti-cancer agent treatment to the patient's need and patient education. When initiating anti-cancer treatment comprising oral anti-cancer agent, it is important that healthcare providers approach the patient in the context of a comprehensive and well-coordinated multidisciplinary team effort that ensures a clear and uninterrupted process of collaborative care without unnecessary visits burdening the patient, that is, seamless care. In addition, with respect to the relationship between patient and healthcare provider, the current premise is that with the exception of technical matters, decisions regarding treatment and use of medication are carried out in accordance with the principle of shared decision-making. This implies that patients are not only adequately informed on their disease, its treatment, and the consequences thereof, and invited to discuss these matters with their healthcare providers, but also that they are explicitly and timely asked after their preferences and wishes. Following the course of the pharmaceutical care process as described in paragraph 32.5, as shown in Table 32.1, both the first dispensing of the medication and subsequent refills are part of a predetermined set of appointments at which treatment effects, results, side effects, social impact of treatment, are evaluated and necessary adjustments are made. It is necessary that prescribing healthcare provider, that is the oncologist, hemato-oncologist, or surgeon, pass the treatment plan including all information relevant to the use of the medication onto the pharmacist and make data, e.g. lab values, or pharmacogenomic data, accessible in time. In the context of this collaborative approach, it is self-evident that there is mutual consultation between prescribing healthcare provider and pharmacist. In this manner, the dispensing of medication can be efficiently prepared and tailored to the patient in a preliminary manner, as shown in Table 32.1. This process also ensures that information about oral anti-cancer agent and co-medication, its use and expected effects provided to the patient by the pharmacist, or designated pharmacy staff, is in line with information provided by the prescribing healthcare provider and oncology nurse. Moreover, thorough preparation prevents the situation that missing data still has to be retrieved in the presence of the patient. Using the preliminary treatment plan at first dispensing, the patient is informed on the relevant particulars of the selected oral anti-cancer agent, mechanism of action, its use, dose and dose regimen, and treatment effects, therapeutic effect, side effects, that can be expected to occur. If applicable, the information is extended both to supportive medication to treat or prevent side effects and co-medication, and their interaction with oral anti-cancer agent treatment. Information given by the patient on the basis of a structured interview may lead to adjustments with respect to oral anti-cancer agent dose and regimen and use of eventual co-medication. The patient is explicitly asked to consent to the finalized treatment plan. The first meeting with the patient is also used to discuss monitoring of treatment and follow-up, weekly to every 3 months, adherence matters and the importance of reporting side effects. It is clearly agreed whom the patient may contact for information and questions between appointments. Relevant data and specifics that have been discussed at the first and subsequent dispensings are documented in the patient's electronic health or medication record. An important element of the dispensing of subsequent oral anti-cancer agent prescriptions after scheduled assessments of the therapeutic effect is asking the patient, by means of a structured interview, after her experiences with oral anti-cancer agent treatment with respect to side effects and impact on social life. If necessary, the patient's remarks should lead to treatment adjustment, interventions that correct non-adherence, or other measures aimed to uphold quality of life. At the start of anti-cancer treatment, patients often receive too much information in a short time interval and are not receptive to information or unable to properly process all data. Apart from the possibility to arrange a follow-up meeting, printed information in a personalized form that is understandable to the patient should therefore be available and given to the patient. Moreover, in addition to information presented in leaflets and brochures, patients should also be alerted to websites where relevant information can be viewed online, hospital, pharmacy, patient association, and made aware of patient associations. It can also be highly useful to introduce tools supporting the patient in the form of medication cards and electronic reminder, reporting services, mobile phone app or interactive website. Next we will discuss the role of the pharmacist in supporting patients using oral anti-cancer agents. Over the last decades, the pharmacy profession has experienced a change from traditionally drug-oriented toward patient-oriented services. As the result, pharmacists and staff in community and hospital outpatient pharmacies now play a significant role in the care of patients with chronic diseases. Due to the rapid progress in cancer treatment, including the introduction of targeted therapies for a growing number of patients, at least some cancer types have also become a chronic disease. Moreover, the increased availability of effective oral anti-cancer agent has reduced the hospitalization rate of cancer patients and improved their quality of life. However, these possible benefits can be jeopardized by an inadequate use of medication, a poor management of side effects, or an insufficient adherence to medication. The latter case particularly applies to patients whose disease has been greatly reduced for a long time or who use oral anti-cancer agents preventively after previous treatment. On the basis of their knowledge and skills, pharmacists may timely identify the increasing number of potential medication-related problems and contribute to their solution. Close collaboration with other hormonal therapy, both in the case that these problems are related to prescribing or that they occur during the course of treatment as the result of disease progression, side effects, or inadequate medication use, is the most appropriate way to resolve these problems. Increasingly, pharmacists are seen as partners of primary care physicians as they collaborate on a variety of care activities, including the optimization of medication, medication reconciliation, patient education, and medication safety. Clearly, as they dispense oral anti-cancer agents and co-medication on a regular basis, pharmacists should play a more prominent role in the care process of cancer patients. Within the multidisciplinary team framework, this means that the pharmacist, or designated staff, proactively informs and advises the, often elderly, patient about the medication, its use, and the consequences thereof, with an emphasis on side effects and their management, and adherence, preferably in the form of a therapeutic monitoring program with patient-tailored interventions applied if necessary. several pharmacist-led care interventions to improve adherence to oral anti-cancer agent, increasingly using modern ICT applications, indeed have shown to be effective. Thus, supporting patients in adhering to their medication has now become a responsibility of community and outpatient pharmacists, as well as playing a prominent role in patient education. However, in view of the growing complexity of cancer treatment and cancer patient care requiring extensive knowledge and experience, and the often very small populations of many less commonly occurring malignancies, the management of the majority of cancer medication can only be properly handled by hospital or specialist pharmacy-based pharmacists familiar with all aspects of cancer treatment with these drugs and other means, specialist care. As the result, in many countries, oncology pharmacy has evolved into a new pharmaceutical discipline. Notwithstanding this requirement, to a lesser extent it also applies to community pharmacists who do not dispense oral anti-cancer agents, but are responsible for the pharmaceutical care of patients using oral anti-cancer agents and co-medication on a day-to-day basis. As the result, these pharmacists, and designated staff, will be much more focused on safe medication use, supporting patients with regard to adherence, and the management of side effects brought about by both the anti-cancer and other, chronic and/or supportive, medication. However, with respect to specific problems related to the use of oral anti-cancer agent, these pharmacists must have direct access to the knowledge available to the specialist dispensing pharmacists, e.g. by means of help desks and/or an electronic knowledge base. In this respect, it would be helpful to establish local or regional information centers where relevant information regarding cancer drugs and cancer treatment is collected, evaluated, and made available either in the form of a help desk or electronically by linking it to the pharmacy information systems. In this manner and with specific training, community pharmacists indeed provide the link between hospital-based cancer treatment with oral anti-cancer agents, first-line care by general practitioners and the patient. Finally, in addition to selecting, prescribing, and dispensing the right treatment, personal contact, commitment, and familiarity with all healthcare providers participating in the multidisciplinary team effort are indispensable contributions to the success of pharmaceutical care for cancer patients. We will now look at a case scenario. Case 1 involves epidermal growth factor receptor mutated non-small cell lung cancer treated with erlotinib and co-medication. Mrs. L., 86 years, widowed since 8 years, has angina pectoris since 10 years. 12 months ago she was diagnosed with metastatic epidermal growth factor receptor mutated non-small cell lung cancer, abbreviated as NSCLC, for which she was prescribed erlotinib, initially 150 mg per day, after 2 months 100 mg per day. As recommended, she takes erlotinib 1 hour before breakfast on an empty stomach, because food increases erlotinib bioavailability, which is associated with an increased risk of QTc prolongation. Each month the erlotinib tablets are dispensed by the hospital outpatient pharmacy. Mrs. L responds well to erlotinib. With some help of relatives she still lives independently and loves to be in her garden. She has also a good cognitive function. Mrs. L also uses the following co-medication: acetylsalicylic acid dosed at 80 mg, once daily for 10 years, metoprolol 50 mg, once daily for 10 years, simvastatin 40 mg, once daily for 10 years, omeprazole 40 or 20 mg, once daily for 7 years, and minocycline 100 mg, once daily for 8 months. Mrs. L visits the local pharmacy to collect her chronic medication for a 90 days period. As its solubility is decreased at pH above 5, the bioavailability of erlotinib is decreased when used in combination with drugs that increase the pH in the stomach. It is therefore recommended to avoid the use of a proton pump inhibitor in combination with erlotinib. However, in view of the need to use aspirin, Mrs. L's age and her history of mild reflux esophagitis, at the start of erlotinib the hospital pharmacist suggested to continue omeprazole but at the lower 20 mg per day dose. Although her malignancy responded well to erlotinib, soon after starting treatment Mrs. L developed serious skin toxicity in the form of papillopustular skin eruptions, grade 3, which in spite of topical treatment, led to a dose reduction from 150 to 100 mg per day, as she felt tempted to discontinue treatment. As a further measure to manage skin toxicity she was prescribed minocycline, tablet 100 mg, once daily. Twice daily she also uses a moisturizing emollient cream. When collecting her chronic medication and cream from the local pharmacy, the pharmacist asked her after her experiences with erlotinib and her skin problems. She told the pharmacist that as such treatment was now tolerable, but that she observed more and more dark spots on her skin. Hyperpigmentation is a well-known side effect of minocycline in dermatology. She also said that she felt somewhat nauseous during the day which, however, usually improved during the evening. Increasingly, she also suffered from aching muscles which effect she attributed to a lack of physical activity as the result of fatigue. Following consultation with her GP Mrs. L switched from minocycline to doxycycline capsules 100 mg, once daily, with the advice to avoid sunlight. The pharmacist also proposed to stop using simvastatin and add vitamin D2, tablet 800 IE, once daily, to her medication. Moreover, the pharmacist also suggested Mrs. L to take erlotinib 2 hours after dinner for a trial period of 2 weeks and to make a consultation after 2 weeks. Mrs. L accepted this proposal. After 2 weeks, Mrs. L returned to the pharmacy and shared her experiences with her modified medication with the pharmacist in the pharmacy's consulting room. Mrs. L said that although the feeling of fatigue had not completely abated, she felt now much better not only by taking erlotinib in the evening, but also because the pain in her muscles had disappeared. Simvastatin use was stopped not only because of Mrs. L's age and life expectancy, deprescribing, but also since the combination of erlotinib and a statin has been related to an increased risk of statin-induced myopathy. Vitamin D was considered necessary because of Mrs. L's reduced physical activity and the advice to avoid sunlight as a consequence of using doxycycline. Case 2 involves adjuvant hormone therapy following early breast cancer treatment and co-medication. Mrs. B, 68 years, is a type 2 diabetes mellitus patient since 8 years. As treatment she uses metformin 500 mg, once daily, gliclazide 30 mg SR, once daily, and simvastatin 40 mg, once daily in the evening. She also has atrial fibrillation for which she now only uses metoprolol 50 mg, once daily, and warfarin. Being diagnosed with early hormone receptor-positive breast cancer, she recently has been successfully treated with surgery, radiotherapy, and chemotherapy. According to the guidelines, the oncologist advised her to use tamoxifen 20 mg, once daily for a 5-year period. The prescription for tamoxifen was sent by email to the local pharmacy. Unfortunately, Mrs. B has not been convinced that she should use tamoxifen. This because she already uses 4 medicines and meanwhile has developed a strong fear of side effects, as she has read on the internet about the horrible side effects of adjuvant hormone therapy, abbreviated as AHT. When she visits the pharmacy to collect her medicines, the pharmacy technician supplies her with a box of 30 tamoxifen 20 mg tablets and asks her what the oncologist has told her about tamoxifen. Mrs. B says that she was told that tamoxifen is an antihormone which use is required to prevent breast cancer recurrence, but that its use would be accompanied by particularly annoying side effects, such as not feeling well, depression, and dry skin. Mrs. B complains that she already is not feeling well, not only because she feels not recovered from her recent cancer treatment, but also because she thinks her diabetes is going out of control. Especially because of the prospect of having to use tamoxifen for such a long period, she has therefore little inclination to start with using tamoxifen. The pharmacy technician feels that Mrs. B needs more support for starting tamoxifen treatment and asks the pharmacist to counsel Mrs. L about the pros and cons of adjuvant hormone therapy. The pharmacist knows Mrs. B because she is a frequent visitor of the pharmacy and is included in the program of the yearly performed clinical medication reviews. In the pharmacy's consulting room, Mrs. B is provided with information on adjuvant hormone therapy, the various side effects including hot flushes, urinary symptoms, tiredness, night sweats, and emotional problems, and their actual risk of occurrence in relationship to the information Mrs. B found on the internet. Because of her ambivalent attitude and many questions, the pharmacist particularly addresses the effect of adjuvant hormone therapy on the recurrence of breast cancer and tells her that in case of side effects she should contact her oncologist. In addition, the pharmacist indicates that tamoxifen can be taken in the morning simultaneously with metformin, gliclazide, and metoprolol. The pharmacist also explains that there is no interaction of tamoxifen with her current medication. However, since tamoxifen may enhance the effects of warfarin, the pharmacist will report her starting with tamoxifen to the thrombosis service, which will monitor this interaction and may adapt the scheme for the intake of warfarin. At the end of the consultation, Mrs. B receives a brochure with all the information and is signposted the websites of breast cancer patient and research associations. After a few days, Mrs. B decides to start tamoxifen and calls the pharmacy to tell it. As agreed, for the first half year she is dispensed tamoxifen monthly, keeping her in a diary how she feels and what side effects she suffers. Although Mrs. B continues to use the tamoxifen without too many problems, after several months she becomes depressed and visits the pharmacy with a prescription for paroxetine. The pharmacy technician enters the prescription in the pharmacy information system. Subsequently, an alert showing a drug-drug interaction with tamoxifen appears. The interaction comprises CYP2D6 inhibition by paroxetine, leading to a reduced formation of the potent tamoxifen metabolite endoxifen, which affects the effectiveness of tamoxifen treatment. The pharmacy contacts the GP, discusses the interaction, and proposes the use of citalopram instead. Thank you.